Welcome to The Explainer. Today, we're breaking down one of the most common, and let's be honest, scariest childhood injuries out there, the broken elbow. If you're a parent, this is one you'll definitely want to know about.
All right, let's kick things off with a question. It's a question that, unfortunately, a lot of parents find themselves asking after a fall from the monkey bars or a tumble off a bike. What is the single most common elbow fracture in kids?
And the answer? Well, it's not even close. It's the supracondylar fracture. Get this, it accounts for a whopping 60% of all elbow breaks in kids. I mean, that makes it the undisputed champ of childhood elbow injuries.
You know, there's a classic story that goes with this injury. Picture it. A kid, usually between 5 and 10 years old, takes a tumble. What's the first thing they do? They stick an arm out to catch themselves, right? It's pure instinct. But that simple protective move is exactly what causes this very specific break.
Okay, so we know what it's called, but what exactly is a supracondylar fracture, and why on earth is it so common? To figure that out, we gotta look at the anatomy, see what's really going on inside that little arm.
And this is the key. The break happens in this naturally weak, really thin part of the upper arm bone, the humerus, just above the elbow. You can almost think of it like the bone has a narrow waist right there. It's kind of like a design flaw which makes it super vulnerable to cracking when a kid falls on it.
Okay, so doctors actually break these down into two main types, and it all depends on how the arm was positioned during the fall. You've got the extension type, which is that classic fall on a straight, outstretched arm we talked about, and then there's the flexion type, which is way less common. That one's from a direct blow to an already bent elbow.
And when I say one is more common, I mean, look at these numbers. It's not even a contest. About 95%, 95 of all these fractures are the extension type. So yeah, that fall on an outstretched hand, it's almost always the reason.
So, once a doctor suspects this fracture, how do they figure out how bad it is? Well, they use this really important system called the Gartland classification. And let me tell you, this isn't just medical jargon, it's absolutely crucial because it literally determines the entire treatment plan.
It's basically a 3-level scale. A type 1 is the mildest. Think of it as just a hairline crack. The bone is broken, but it hasn't moved out of place. A type 2 is a step up. The bone has shifted, but there's still a little piece of bone connecting the two parts, kind of like a hinge. Then you have type 3, and that's the most serious one. The bone ends are completely separated, with no connection at all.
Okay, let's walk through the process. How do you get from a kid crying on the playground to a confirmed diagnosis in the hospital? Let's talk about the signs to look for and what you can expect in the ER.
Right after the fall, the signs are usually pretty obvious. I mean, of course, there's going to be severe pain and a lot of swelling. But here's the big tell. Look for a distinct S-shaped curve to the arm. If you see that, that's a massive red flag. You're definitely dealing with something much more serious than a sprain.
Once you're at the hospital, things move in a very specific order. First, the doctor listens to the story of the fall, which raises suspicion. Then, x-rays are taken to confirm the break. After that, they'll assign the Gartland type. But the fourth step, this one is the most important of all. It's the neurovascular check. They are meticulously checking for any damage to the nerves and the blood vessels that, and this is key, run right next to where the bone is broken.
All right, so the diagnosis is in. The fracture is classified. Now for the million-dollar question, how do they fix it? Well, the game plan depends entirely on that Gartland type we just talked about.
It's a really clear roadmap. If it's a simple type I, where the bone hasn't shifted, it's usually just a cast for about 3 weeks. Easy enough. But for the more serious type 2 and 3 fractures, you're looking at surgery. This typically means a closed reduction, which is a fancy way of saying the doctors manipulate the bone back into place without making a big cut. Then, they'll insert a few small pins through the skin to hold everything together while it heals.
But here's the thing. Whether it's a simple cast or a full-on surgery with pins, the two main goals never change. Goal number 1, get that bone lined up perfectly so it heals straight. And goal number 2, which is arguably even more important, make sure nothing is pressing on or damaging those critical blood vessels that feed the hand.
So, getting the bone fixed is the first big step. But what happens next? What does the road to recovery actually look like?
Well, the really good news here is that kids heal incredibly fast. Usually the cast or pins are out within 3 to 4 weeks. Right after that, they'll start some gentle physical therapy to get that elbow bending again. And if there was any minor nerve bruising from the break, that almost always clears up on its own within about 2 months.
Now, the recovery is usually pretty smooth. But, and this is a big but,
There are some really serious risks that make orthopedic surgeons sit up and pay close attention to this particular fracture. So what are they so worried about?
Okay, so doctors are on the lookout for 4 main complications. Nerve injuries are actually pretty common, but thankfully, they're usually temporary. Then there's something called cubitus varus, where the bone heals a bit crooked. It's not ideal, but it's mostly a cosmetic thing. But the last 2, these are true 5-alarm medical emergencies. First, vascular compromise. That's damage to the main artery. And second, compartment syndrome. This is a dangerous, rapid swelling inside the arm that can literally choke off all blood flow to the hand.
And that brings us to the final, and honestly, the single most important takeaway from this whole explainer. When a doctor is looking at this injury, what's the one thing that's even more vital than what they see on an X-ray?
The answer comes down to this statistic: 10 to 20%. What does that mean? It means that in up to 1 out of every 5 of these cases, there's a risk of injuring the brachial artery. That's the main highway for blood flowing to the forearm and hand. And that is what elevates this from a simple broken bone to a potential medical emergency.
So here's the bottom line. You can have an X-ray that shows the bone is perfectly lined up, a textbook fix. But that perfect X-ray means nothing if the child's hand is cold and pale because blood isn't getting down to it. You can always fix the bone later. You can't fix a limb that has lost its blood supply.
And that leaves us with this incredibly powerful clinical rule of thumb that every doctor lives by, and frankly, every parent should understand too. When it comes to supracondylar fractures, the pulse is more vital than the X-ray. Feeling that strong, steady pulse at the wrist tells you more and is more important than any picture of the bone. It's the ultimate sign that the limb is alive and well.